Today we are going to discuss about myasthenia gravis. So yes, it has been coming from MBBS first year onwards. Okay, coming since MBBS first year. So today we are going to discuss this topic. So what is myasthenia gravis basically? So myo means muscle, asthenia means weakness, gravis means severe. Severe muscle weakness is known as myasthenia gravis. It is an autoimmune disease. Antibodies to the post-junctional acetylcholine receptors and also the antibodies to muscle-specific kinase leads to this disease. Autoantibodies to pre-junctional voltage-gated calcium channels. This is presynaptic voltage-gated calcium channels. So to this, if the autoantibodies are generated, then the disease is specifically called as Lambert-Eaton syndrome. There are only some mild differences between Lambert-Eaton syndrome and myasthenia gravis. Okay. So coming to the etiology, it is commonly seen in individuals of 15 to 50 years. If it is occurring in young individuals, then the females are more affected than the males. If it is occurring in the older age groups, then the males are commonly affected than the females. Okay, and in case of thymoma patients, what happens? Thymus is the gland which produces our autoantibodies, means antibodies actually. T lymphocytes thymus is producing, right? So here what happens in thymoma patients, due to sudden increase in the size of the thymus gland, there are autoantibodies generated, so which act against this postsynaptic acetylcholine receptors, which leads to this disease also. Okay, thymoma is also a reason. Okay, pathogenesis, in case of thymoma patients, there will be increased cell mediated immunity, so the T cells which generate autoantibodies against the acetylcholine receptors. Okay, this is that. Okay, and if there is absence of thymoma also, our humoral immune response is present, which generate the autoantibodies against the acetylcholine receptors. So already we had discussed what is Lambert-Eaton syndrome, which is a presynaptic voltage-gated calcium channels. Against there will be autoantibodies, then there will block of calcium influx, then there is no fusion of synaptic vesicles to the presynaptic membrane. Okay, then there is no release of acetylcholine from the synaptic cleft. Okay, so it is a degenerative disease. The antibodies blocks the attachment of the acetylcholine to the acetylcholine receptors. No cholinergic effect is seen. Antibodies to presynaptic voltage gated channels inhibits the fusion of vesicles to the presynaptic membrane and acetylcholine release. Just now we had discussed. Only motor response is affected, no sensory involvement. Coming to clinical features, what the patient complains of? Mainly patient complaints presents with diplopia, ptosis and muscle weakness. Okay, and paresthesias. Sometimes the patient, in many cases the patient is unable to speak properly and swallow properly if the speech muscles and deglutition muscles are affected, then this will happen. If the respiratory muscles get involved, then death may happen, means that is if there is any phrenic muscle paralysis or intercostal muscle paralysis due to the involvement of intercostal nerves and phrenic nerves, then there will be palsy of the respiratory muscles, which leads to death if not properly treated immediately. Okay, weakness is gradually progressive in this case, and coagulants lid twitch sign will happen, means suddenly the patient will be elevating the lid and some like twitching movements will occur, and again drooping of the eyelid will occur. Patient is unable to undertake the task above the shoulder level in case of 11th nerve involvement. Okay, which leads to struggling of shoulder and all. Okay, spinoglossal nerve involvement. Aspiration may occur if in case of glossopharyngeal nerve is involvement, if cough is ineffectual. Okay, there may be aspiration pneumonia seen with the patients. Any ocular myasthenia, there will be only ocular myasthenia, there is no other involvement, means the patient had good prognosis. Okay, coming to the investigations, serum analysis we will do for anti-acetylcholine antibodies if there are any present. If the acetylcholine antibodies are absent, then we will go for anti-muscle specific kinase antibodies in cases with prominent bulbar involvement. So electromyographic studies we will do. So in the involvement of ocular bulbar involvement, we will do electromyography also, CT, MRI, so for ruling out the thymoma in case of seronegativity. These two tests are negative, then we will go for this also, CT and MRI. So if any thymoma is present or not. Tensilon test, so this is also known as hydrophonium test. First we will inject 2 mg of hydrophonium, okay, through IM or IV. Then we will wait for the symptoms to subside. If the symptoms subside, then it is due to the Myasthenia gravis, and till 8 mg also we will ingest, and we will see. If the symptoms are not subsiding, then we should go for other any differential diagnosis, okay. That is hydrophonium test, okay. Coming to so this we had already seen. If the symptoms are not subsiding, then we will increase the dose. If they are not subsiding, then the disease is not due to the Myasthenia gravis, so we should go for any other differential diagnosis. Treatment is so we will go for, if there is any, we should inhibit the acetylcholinesterase, so we are giving pyridostigmine. Means already there are autoantibodies to acetylcholine receptors. Then again, if there is a overactivity of acetylcholinesterase, then there will complete degradation of the acetylcholine, so we should give pyridostigmine. If there are any muscarinic side effects, we should give propanthyline for the subsidation of the muscarinic side effects. Myasthenia crisis, IV administration of the immunoglobulin should be done. Plasma exchange therapy, so to in plasma only antibodies will be present, right? So we should be removing these autoantibodies through plasma exchange therapy. Corticosteroids are given. Monitoring the patient's respiration. Thymoma, any joint oncology and thoracic surgery. Thoracic surgery we will be doing for thymoma. And younger seropositive patient with generalized disease will go for thymectomy, okay. Aminoglycoside antibodies, okay, if they are present, they worsen the Myasthenia gravis. Immunological treatment of myasthenia. Acute treatments are IV immunoglobulins, which lowers the antibody production, reduces the weakness. Plasma exchange, which removes the antibodies from blood. Okay, in case of Myasthenia crisis, preoperative preparation, we will do plasma exchange. Long-term treatments are glucocorticoid treatment. Start glucocorticoid low dose and increase gradually. High dose steroids require hospital administration. Necessary to continue for months or years. There may be adverse effects due to immunosuppression. Pharmacological immunosuppression, azathioprine 2.5 mg per kg, which decreases the dosage of the glucocorticoids. So you should be giving azathioprine also. So if you are reducing the dosage of corticosteroids, so you should give azathioprine. Means if you are giving azathioprine, there will be addition in immunosuppression, okay, right? Additional immunosuppression, so you should be reducing the dosage of the glucocorticoids. Another drug is mycophenolate mofetil, and rituximab also should be given. Thymectomy, which is required for thymoma patient. If any antibody positive patient under 45 years with symptoms not confined to extraocular muscles, and the disease has been spread and it is been for greater than 7 years, then you should be doing thymectomy, okay. Patient is should be under 45 years, but the disease is for greater than 7 years, so you should be doing thymectomy. If the older patient is present, then you should be doing thymectomy directly. Younger patient greater than 7 years means you should be doing thymectomy to them. So that's it guys for today. Actually this topic should be done later. Viral hepatitis also will be covering later topics, okay. Thank you guys, thank you for paying attention. This is all. Myasthenia gravis is a autoimmune disease, so autoantibodies will be produced to acetylcholine receptors in the postsynaptic membrane, and Lambert-Eaton syndrome, you will be seeing autoantibodies to presynaptic calcium channels. And we talked about pathophysiology, and in case of thymoma also there will be autoantibody production, and so there is a decreased acetylcholine, so a patient will be presenting with the means choline will be decreased, so confusion, diplopia, and motor action is mainly affected than sensory action, and diplopia, facial weakness, difficulty in swallowing, difficulty in speaking. These will be the complaints of the patient. So we should be doing serum analysis for seeing the any auto antibodies are present for presence, and muscle specific kinase auto antibodies are present or not. After that we should be doing CT or MRI to rule out any thymoma is present or not. So and heterophonium test, tension test, 2 mg to 5 mg. If any substitution of the symptoms, then we will be directly saying it is myasthenia. If there are no subsiding of the symptoms, then you should be going for any other diagnosis. So here treatment will be pyridostigmine. So it should be inhibit the acetylcholinesterase. Okay, if any muscarinic side effects occurs, then you should be giving the propantolin. So in case of myasthenia crisis, you should be doing IV administration of immunoglobulin, plasma exchange therapy, corticosteroids. So in thymoma, you should be doing joint oncology along with the thoracic surgery. Younger patients with generalized disease means you should be doing the thymectomy. Aminoglycosides antibodies will worsen the disease. So you should be doing acute treatments, IV immunoglobulin, plasma exchange, and long-term treatments are corticosteroid treatment. In case if you are giving azathioprine 2.5 mg per kg, you should be reducing the dose of corticosteroids, and thymectomy is required if the patient is a younger patient, less than 45 years, greater than 7 years the disease is there, means you should be directly going into thymectomy. That's it guys today. This is myasthenia gravis, which is at important autoimmune disease, and it is short, it is like a short note they may given. Okay, they may give. Okay, thank you guys, thank you for paying attention.